Welcome. Thanks for joining this Micron Wellness Healthcast. It is July 2012. Today we have the pleasure of having a speaker from our Boise community, Dr. Robert Haake. He has an interesting background, served 25 years as a nephrologist and in critical care, and has recently shifted the focus of his practice to treating patients in or near menopause and andropause. His goal with his patients is optimal youthful physiological function. Today, the title of his presentation is Anti-Aging and Functional Medicine, and he has a lot of great information to share with us, so I will hand it over to Dr. Robert Haake.
Thank you very much. Thank you for having me here today. I was going to focus this discussion on my matrix that I use for health, and I was going to focus that on testosterone, but after looking at my audience, I'm going to change the focus a little bit on estrogen, so we're going to talk about estrogen as well. As was mentioned, I am a critical care doc and a nephrologist. I practice mostly nephrology prior to coming here to town. Since I've been here in town, I've done hospitalist work at St. Luke's, and I also work part-time for Idaho Nephrology Associates. And in that context, I take care of patients. Is this working here? I take care of patients who have end-organ disease. They have end-stage renal failure, and they may have multiple system organ failure. These patients are often elderly. They're physiologically old if they're not chronologically old. They have multiple problems, and we address this in a very aggressive and invasive and expensive and labor-intensive way. That model of medicine, I think, is appropriate for this patient population. For the most part, and there's other things we could do, but for the most part we're constrained by what we can do for these people. The problem comes when we use that same paradigm to treat people who are reasonably healthy. And I've often thought to myself, what if I could go back 20 years or 30 years, 25 years, and get these people and get them to do the right things and sort of reestablish a physiologic youth, and I could obviate going down this path of worsening pathology. And so that's what I'm doing now. What I'm doing is I'm trying to get people who may be starting to experience some of the problems. So the conventional allopathic medicine is expensive, aggressive, et cetera, and that's what I'm trying to address here. Model and paradigm appropriate for the patients with end-stage renal failure or end-stage cardiomyopathy, but not for the relatively healthy people. Now, this is based upon a different philosophy of medicine. The philosophy of medicine is that you're sick, I'm going to cut, burn, poison you back to health. That's cynically kind of what we do in conventional allopathic medicine. But what if we took a different approach and we said, we took a different hypothesis and we said maybe we're genetically programmed on a biochemical and an endocrinologic and physiologic level to maintain health and to heal ourselves if we're given the right conditions. So what I'm going to talk about today is the right conditions. And I want to talk about also how this, in just an example of how this approach differs from the conventional approach. The conventional approach is I have a 50-year-old man comes in my office and he says, you know, doc, I'm tired all the time, I'm fatigued, I get brain fog, I can't remember anything, my libido's low, I got some erectile dysfunction, I can't sleep, I'm getting fat, I'm losing my strength, I'm losing muscle mass, my mood is kind of low. What's a conventional doctor going to do? He's going to say, you're obviously depressed, you need some Lexapro or some Zoloft or Paxil. You can't sleep, here's some Ambien. Oh, by the way, your cholesterol's up a little bit, here's some Lipitor or Crestor for you, and we'll give you some Avandia for your blood sugars being high. And oh, by the way, blood pressure's a little high, we better put you on some lisinopril or some amlodipine or whatever. So the guy leaves your office and he's got 5 or 6 medications. We're making a lot of money for Big Pharma. And what are we doing for this guy? We haven't addressed the underlying pathophysiology of his problem. And what we've done is we've done medical cosmetic repairs. This is cosmetic medicine, internal medicine, as opposed to cosmetic surgery. This is cosmetic medicine. Because when he comes back, his sugars might be better and his cholesterol might be a little lower, but chances are he's not going to feel any better and he's going to have problems. He's going to have side effects from these drugs. And what's the big underlying problem with a lot of these men, for example, that come in with this problem? Well, aside from poor nutrition, not exercising, not having the right micronutrients, I've just described somebody with hypogonadism. So his testosterones are low. Most doctors will look at that and say, well, yeah, you got the level but you're in the normal range. Well, the normal range goes from the average 80-year-old to the average 17-year-old. Where would you rather be? You know? So Before I get into this template that I've developed, I just want to go over what I think are the underlying causes of the pathophysiology of disease. The big one here is inflammation. Inflammation is the final common pathway of all disease, whether it's cardiovascular disease, whether it's cancer, whether it's neurocognitive problems, rheumatological diseases, etc. And inflammation is the biggest cause of early aging because it's inflammation that causes your telomeres to shorten. Telomeres are the sequences of DNA, the redundant sequences of DNA that extend out of the chromosome. Every time the somatic cell divides, the telomere then tells the cell, don't divide as often. So when it doesn't divide as often, senescence sits in, and what senescence is that your cell is starting to accumulate metabolic junk, glycation end products, oxidizing hits to the mitochondria, to the DNA, etc. So inflammation is the big problem. Inflammation and high blood pressure and certain other things will cause endothelial cell dysfunction. Endothelial cells are the cells that line the blood vessels in the body, particularly the arterioles that we're concerned about, the arterioles and the arteries. They are very metabolically active, and some physicians and researchers look at it as a system in and of itself. They produce a number of intermediates, and they produce a number of things that are key to staying healthy. If they develop dysfunction, this is what causes the arteriosclerotic vascular disease and the subsequent myocardial infarction, stroke, etc. Insulin resistance, a big problem. We have patients that come in that have elevated blood sugars, and so the first thing the doctor does, he doesn't look at their insulin levels, which may indeed be high, and high insulin levels are really causing a big number of problems. But what they do is they say, well, we got to get your sugars down, we'll give you hypoglycemic agents or insulin itself, which further increases an already elevated insulin, because it's insulin resistance that's the problem. High insulin is what's causing basically the metabolic syndrome. High insulin is causing inflammation, it's pushing up your cholesterols and triglycerides. High insulin is causing the elevation of the blood pressure, or it's at least a component of the elevation of the blood pressure. Glycation, this is where your blood sugars are high. Glycation is a glucose attaching itself to cholesterol molecules. When glucose attaches itself to a cholesterol molecule, it's much more easily oxidized. It's only when it's oxidized can it be absorbed or ingested by a macrophage to form a foam cell and therefore atheroma. So what we're brainwashed to think is that high cholesterol is somehow in and of itself a problem. We have huge populations of people that have high cholesterols that don't die of stroke or heart attack. Conversely, we have people coming into the emergency room with an MI, 60% of which have normal cholesterols. So clearly, cholesterol is a component to this picture, but not the focus of the picture. So it's a glycation of the cholesterol, it's a glycation of protein that's causing damage. So we don't want high sugars, we don't want high insulin. The high insulin and sugars come because of insulin resistance. There's an accumulation of toxins in our body, and this is something that is very, very important, something that contemporary medicine just ignores. These are toxins such as heavy metals. There's such things as petrochemicals, halides, fertilizers and herbicides, pesticides, breakdown products of plastics, etc. These things are accumulating. Many of these are xenoestrogens. Many of these are pro-oxidant agents. I read one quote about studying the level of just lead in babies. They find that now a newborn has 2,500% more lead than the bone content that's found in men who live, or people who lived 500 years ago. Just to give you an idea of the accumulation of these toxins. So any approach to this would have to take into account how we're going to detoxify people. Now, there's obvious ways of just drinking clean water, taking in organically grown fruits and vegetables. We can use vitamin C, which is a chelator. We can use iodine, which chelates, but there are other more advanced ways of detoxifying. The other problem is in the common pathophysiology is the downregulation of the hormones. And the hormones, we're not only talking about estrogen in women and progesterone, and testosterone in men, but we're talking about progesterone, DHEA, pregnenolone, melatonin, growth hormone, etc. Now, this matrix that I came up with, first and foremost, to get people healthy, to reestablish this physiologic youth, what I need is, I need people to be eating correctly. So what I've done is I've studied a bunch of different diets, but they're really not diets. They're philosophies or approaches to eating. They include such things as a Paleolithic diet and the Mediterranean diet, the South Beach diet, etc. And what I've done is I've integrated their points or their essential features or their pearls, and I've come up with what I call my macronutrition axioms. So if you follow these things, what's going to happen? If you do these things, you're going to tend to become lean. And there are going to be things like eat breakfast every day, eat every 3 hours, eat plenty of protein. You want to avoid you want to take in organically grown fruits and vegetables. You want to avoid grains if possible, certainly gluten. Best forms of protein are things like fish, etc. But there's a whole list of about 20 things that I think that people should be following. If you're doing these things, you don't really need to ever diet. In fact, dieting never makes sense because you're constraining calories, and you never ever want to constrain calories in patients. What you want them to do is eat nutrient-dense foods and adequate calories combined with the right exercise, and you should get lean. Weight is irrelevant. We don't care about weight. What we care about is body percent, fat percent in the body. That's the important thing, not the weight. Some people are just going to carry more muscle, so weight is never a goal. Weight loss is never a goal. The other thing is the essential micronutrients, and the essential micronutrients that I talk about are such things as a good multiple vitamin. Good multiple vitamin is important. A lot of people say, well, doc, I'm eating organically grown fruits and vegetables, nutrient-dense food, I don't need it. Well, yeah, you do, because the soils are depleted in vitamins, cofactors, coenzymes, trace elements, organic acids, etc. So a good multiple vitamin is needed. I put patients on vitamin C in higher doses. Most animals make vitamin C. They make enough vitamin C to keep them healthy. If we would take in as much vitamin C as the average animal synthesized, we'd have to take in about 10 grams of vitamin C a day. Vitamin C is a parent antioxidant. It reconstitutes vitamin E and A and the other tissue antioxidants. It is necessary for collagen synthesis. It's necessary for carnitine synthesis. Not to go through this. This is a lecture in and of itself, but other things that I add are things like vitamin D, omega-3s, antioxidants, free radical scavengers, iodine. According to Guy Abraham at UCLA, 96% of the population is low in iodine. You need iodine to upregulate the production of your thyroid hormones and to transfer T4 to T3. You need iodine to make the steroid hormones. You need iodine for all the receptor sites in your body. 96% of the people are low in iodine. Another thing about iodine, when iodine is low, estrogen is overexpressed in women, which is a big problem with this estrogen dominance phenomenon that we're seeing in women. The estrogen also that is in our environment is also what I think is downregulating the production of testosterone in men, which I'll talk about in just a second. Other things we need is sometimes individuals may need selective micronutrient replacement if they're nutritionally very poor, and I can do assays, biochemical assays looking for antioxidants, organic acids, amino acids, etc. Sleep, very important. We have a whole nation of people who are not getting enough sleep. A big reason for that is obstructive sleep apnea. If I think people have obstructive sleep apnea, they get a sleep study. If you have obstructive sleep apnea or not sleeping properly, you're going to develop pulmonary hypertension, systemic hypertension, obesity, depression. Right-sided heart failure can develop, arrhythmias, atrial fibrillation, depression, on and on and on. So sleep is essential. Sometimes people don't sleep because they're taking in too many toxins. Sometimes you don't sleep because you don't have enough melatonin or even progesterone. Progesterone is a natural sedative hypnotic. It converts into allopregnenolone, and I give men progesterone. So I had a pharmacist call me the other day and said, "Is this right, doc, you're giving this man progesterone?" I said, "Yeah." And he said, "Well, I've never heard of that." And I said, "And?" And he said, "Well, do you have any literature on it? I've never seen it." So I sent him like 100 references on it. And yes, there's literature that shows that men need a little progesterone. Just like men need a little estrogen, women need testosterone. So if you're getting hormone replacement and you're not getting testosterone, you're missing out. Detoxification, I just talked about that. Natural detoxification is exercise, taking in plenty of water, vitamin C, iodine. There's other things that I'll add to this as time goes on. Exercise, very important. Aerobic exercise is important for your cardiovascular system. You're not going to lose much body fat with aerobic exercise. It's extremely important, though, for your cardiovascular system, to get your pulse down, your blood pressure down, etc. It has to be balanced with anaerobic exercise or resistance training. Resistance training probably benefits the perimenopausal, postmenopausal women more than anybody, because as they age, they're going to become rapidly sarcopenic, meaning losing muscle. The same thing will happen to men, but it won't happen as rapidly. So the people that benefit the most are aging people, and especially women. So who should be in the gym pumping iron are not 25-year-old studs, but their moms. And then we'll talk about hormone replacement therapy, and what I do is what conventional doctors do is they say, oh yeah, your testosterone's low, let me give you 100 milligrams every month, and so that gets it up maybe almost normal for 3 or 4 days, and then it comes back down for the rest of the month. They don't check levels, they don't know how to give it, and there's other hormones that have to be replaced, a whole slew of hormones. They work synergistically, they're balanced. You have to harmonize these hormones. I replace them to youthful levels. Some doctors, even endocrinologists, will say, well, they're low, I put them into the low normal range, and if that doesn't work, I add pharmaceuticals. And I'm going, why? You know, the average range of testosterone that we see is from an average 80-year-old to the average 17-year-old. Why wouldn't you push it toward that 17-year-old guy rather than leave it close to the 80-year-old guy? You know, it doesn't make any sense, and the data doesn't support doing it that way. The data supports that you give youthful levels of these hormones. Not doping on them, not giving you synthetic hormones, not giving anabolic steroids, but pushing your normal hormone profile into an optimal level. Telomere lengthening is something that's going to be in my matrix in the future. Why we age and why we develop a lot of the diseases, the age-related diseases, is because the telomeres shorten. Telomeres are these redundant sequences of DNA that extend out of the chromosome. And what they do is every time the cell divides, that telomere shortens. The telomere then tells the cell, don't divide as often, the cell accumulates metabolic junk. It accumulates oxidizing hits. Oxidizing hits to the mitochondria results in less ATP. Oxidizing hits to the DNA results in damage done to the DNA. DNA loses its fidelity of replication, meaning that you then make abnormal protein, abnormal enzymes, and you may make, if the cell divides, the cell may be abnormal. If the cell is abnormal enough, it's called cancer. So again, it's the inflammation that's the underlying problem that's causing, especially oxidizing damage, causing the telomeres to shorten quickly. So the enzyme called telomerase keeps the telomeres long, but it doesn't exist in somatic cells. It exists in cancer cells and in germ cells. So germ cells, eggs and sperm, are immortal, okay? But your somatic cells are dying. In the somatic cells, the rest of the cells of your body, the telomerase is turned off at conception. We now have nutraceuticals that are highly refined that can turn on the telomerase, to turn on this robust cell turnover, to make these cells very youthful, so we don't accumulate this metabolic junk, the glycation end products and the oxidation to these cells. And the final thing is that we now have ways of boosting the stem cell production within the bone marrow and mesenchymal stem cell production. And we can guide the differentiation of these stem cells into progenitor cells. For example, just upregulating testosterone will stimulate the differentiation of these bone marrow stem cells into what is called endothelial progenitor cells. Endothelial progenitor cells are the youthful cells within the lining of the blood vessels. They're the cells that are producing the most robust amount of nitric oxide. Nitric oxide produces cyclic GMP. It causes vasodilation. It keeps your blood pressure low. It has a reduction in the resistance and increases cardiac output. So we can do these things now, and this is all part of my template or grid that I use. I use bioidentical hormones because it just makes sense. Why would you give somebody that's now, bioidentical hormones don't mean that they're not synthesized. They're synthesized from wild Mexican yam or diosgenin in the lab to make identical testosterone, progesterone, estrogen, etc. But they are, so in that respect, they're synthetic, but they're exactly what's in your body. So, but why would you put it something that's actually a drug in your body? It doesn't sit on the receptor sites properly. It's not metabolized properly. They work better. People have less side effects from it. You have better results from it. And again, you understand what it's doing. It should be there in the body. It just makes intuitive sense as well as medical sense. The hormones that I frequently supplement include progesterone, testosterone, cortisol, DHEA, thyroid hormones, which are both T4 and T3. The active hormone there is T3. Problem is, most doctors don't look at your T3. They look at the TSH, which is the pituitary's response to your thyroid. It's like looking at your testosterone level by looking at your luteinizing hormone from the pituitary. It's not very accurate. And if the TSH is high, they say, well, you may have hypothyroidism. We'll check your T4. T4 is a pro-hormone. It's converted into the active hormone T3. So I check TSH, I check free T3, and sometimes T4. I bring them into a optimal range. Same thing with human growth hormone, IGF-1, estradiol, estriol, melatonin, and occasionally things like parathyroid hormone, oxytocin, aldosterone, pregnenolone. But generally, these are the big ones that I'm looking at. Conventional medicine, again, is not looking to bring these things into an optimal range. They're satisfied with you being in the normal range. So, for example, somebody comes in and they're very hypothyroid clinically. They're gaining weight, they can't get rid of the fat, they're cold intolerant, they have lethargy and low energy levels, they have cognitive dysfunction, mental fog, dry skin, constipation, brittle hair, on and on and on. The doctor looks and says, well, your thyroid's in the normal range, it's okay. Your free T3 and your TSH might be the high normal range, and your T4 and T3 are very low, but they're in the so-called normal range. Well, I think that's nonsense. It's an arbitrary decision whether you're hypothyroid or euthyroid based on that. It's a bunch of old endocrinologists sitting around a room deciding this is going to be the normal range. And why not take people into the optimal range? What's the problem with that? You know? So, now we'll talk about estrogen. Estrone is more of a byproduct than the others. Estrone is really not needed to be supplemented. Estrone has some capacity when it forms 4-hydroxyestrone and 16-hydroxyestrone to be carcinogenic. So we try to guide the path, guide the metabolism of estradiol, which forms these metabolites as well, away from 4 and 16 toward 2-hydroxyestrone. We'll talk about that. Estradiol has 400 separate receptor sites in women. And so to say, well, women are going through menopause, I'll just go ahead and give them a little bit of estrogen because they got hot flashes and night sweats and they got brain fog and they're fatigued and they've got some palpitations and urogenital symptoms. We'll give them that we'll give them some pregnant mare's desiccated urine for 6 months and then you're good. Baloney. There's 400 sites, receptor sites women need for estrogen. Men have some as well. And so I look at it as like, well, no, we need to give it. Estriol is added to the estradiol because it helps attenuate the pathogenicity of the estradiol. Estradiol can have some carcinogenic potential when it's broken down, like I said, into 4-hydroxyestrone or 16-hydroxyestrone. The estradiol sits on that estrogen receptor and displaces these toxic metabolites. Estriol also is good for the skin and the vaginal mucosa. It increases collagen and it plumps the mucosa as well as the skin so that you have that target site for estriol. So I give estriol with estradiol, and it's the same as Biest, but I adjust it topically as a topical cream. This is a pathway that's the same pathway in the testicles, the same pathway in the ovaries, same pathway in the adrenals. The only difference is that we have different end products. In the adrenals, cholesterol goes to pregnenolone, progesterone, down here to corticosterone, and then to aldosterone. Aldosterone maintains salt and water balance, acid-base balance in the kidneys. It also the progesterone goes over here to 17-hydroxyprogesterone, down to cortisol, which we need for inflammation. Without it, you die. You need it. But cortisol's got a catabolic effect and a toxic effect that is attenuated by DHEA, dihydroepiandrosterone. This is the most abundant hormone in your body when you're youthful. This goes down as a function of aging. So what the adrenals do is they make these 3 hormones principally. They make all of these others, but principally they're generating these 3. Testicles, same pathway, but they're making mostly, this is testosterone, not testosterone, but testosterone and dihydrotestosterone. The ovaries principally make an estradiol, this is the British way of estrogen, estradiol and progesterone. So same pathway but different products. So the idea here is to supplement not only the estrogen, but to supplement it with progesterone, not only testosterone, but to make sure dihydrotestosterone is elevated. If somebody has adrenal fatigue and their cortisol is low, they also have to have enough aldosterone. They have to have enough DHEA. This is just, I won't go through this, this is just the hypothalamic pituitary gonadal axis in women, and there's a natural feedback inhibition of progesterone and estrogen to the brain after they go up. The female cycle, of course, is progesterone and estrogen tend to be high in the second part of the cycle, and this is when we measure estrogen and progesterone in the premenopausal women to see about, because we know where it should be at this level. They're both highest at this level. And so what I end up doing in premenopausal women is sometimes just augmenting the progesterone and estrogen, trying to copy the normal physiology. So the first part of the month, I won't give much of any progesterone. The second part of the month, I give a little if they need it. The estradiol, we will usually give from day 5 through 25. And then, of course, testosterone. Women need the testosterone as well. Here's a number of things that estrogen does. I'm going to talk about like 20 different things. There are 400 things. But what it does is that it promotes mineralization of the bone. It actually doesn't mineralize the bone. It inhibits bone breakdown. It inhibits the osteoclastic activity. Progesterone, testosterone, melatonin, DHEA, human growth hormone all promote mineralization of the bone. And they're given usually concurrently with the estrogen. Estrogen thickens the skin by putting collagen in the skin and increasing the moisture in the skin. It preserves the integrity of the teeth and the gums. It upregulates the insulin receptors. It upregulates the basal metabolic rate. At optimal levels, it helps convert T4, the inactive form of thyroid, to the active thyroid. It will increase the elasticity of the small blood vessels, so therefore it increases blood flow. It inhibits platelet aggregation. It inhibits atheroma formation. It inhibits the atheroma formation, and the atheroma is, of course, the arteriosclerotic vascular disease, hardening of the arteries. So a 40-year-old woman comes into the emergency room, and she has substernal chest pain with diaphoresis radiating into her shoulders, and she has shortness of breath, but she's still menstruating. Everybody kind of just yawns and goes about their business. They'll check her enzymes and whatnot, but the likelihood of her having an MI is very, very remote. But once she loses that estrogen, she rapidly catches up with men in terms of the incidence of arteriosclerotic vascular disease. And it's probably mediated by the fact that estrogen lowers LDL cholesterol, lowers lipoprotein A, lowers blood pressure, lowers cytokine levels, CRP, will lower homocysteine levels. To change the pace here, what estrogen does is very necessary for women's brains. It upregulates ACH, acetylcholine. Acetylcholine is a principal neurotransmitter in places like the hippocampus. Hippocampus is the center for learning and memory. But the ACH is acetylcholine is throughout the entire brain. So concentration, feelings of well-being, reasoning, other cognitive parameters are affected by estradiol. Estradiol stimulates the neuronal stem cells, the nerve growth factor. It balances the excitatory and inhibitory activity within the brain. And it will, of course, it's a component of libido. So women need, unlike men who come in, they're having a little problem, their libido's low, you put them on some testosterone, they're good to go. Women, a lot more complicated. They may need some estrogen, they may need a little oxytocin, may need a little melanocyte-stimulating hormone, drop the cortisol, etc. So, but it is a component. Without estrogen, there's very little libido. And the same thing for men. I have men coming in and they say, "Doc, you know what? I don't need any estrogen. So, I don't need any." And I said, "Well, you really do." "No, I don't need it, Doc." "Well, if you don't have any estrogen, you can't get an erection and you won't be able to think." "Well, I'll take a little." "Well, I'll take that's okay, Now, a lot of doctors give estrogen orally. There's a big problem with oral estrogen. First of all, usually it's synthetic, birth control pills, etc. Big problem with anything synthetic. Pregnant mares, desiccated pregnant mare's urine makes no sense. It's horse estrogen. But even if you're given bioidentical estrogen orally, there is a tendency for problems. They include increased body fat, increased triglycerides. Triglycerides go up because you have some insulin resistance. Estrogen orally, first pass through the liver, causes some problems. It causes insulin resistance. Insulin resistance means that the pancreas has to pump out more insulin. When that does that, the higher insulin pushes up blood pressure. Higher insulin stimulates the kidneys to hang on to salt and water. It stimulates the smooth muscle cells to undergo hyperplasia in the arterioles, the impedance vessels, so that they're thicker and there's more resistance. So blood pressure goes up. And higher insulin activates the enzymes that push up triglycerides and cholesterol. The higher the oral estrogen also increase inflammatory cytokines, these pro-inflammatory mediators that come principally from white blood cells. And we measure that by looking at CRP, C-reactive protein that's produced by the liver. It itself is a mediator of inflammation, and it's a measure, it's a marker for inflammation. It increases fibrinogen and may have other effects that increase the tendency for clot formation. It increases the incidence of gallstones. It interferes with human growth hormone's effect on the liver to make what we call IGF-1. Human growth hormone is a quality of life hormone. It's anabolic for all tissue, eyes, hair, skin, all the organs in the body. It mediates 75% of its effect through the hepatic production of IGF-1. That effect is impaired with oral estrogens. Oral estrogens will inhibit conversion or the production of the IGF-1. Just anecdotally, I've had women come in that are taking oral estrogens, and I check their IGF-1 levels because that's how we measure human growth hormone. Human growth hormone has a half-life of 8 minutes, IGF-1 about 8 hours. When I check them, invariably, what I found is their IGF-1 levels are extremely low, and this is the oral estrogens interfering with that. So the oral estrogens will also result in an increased production of 4-hydroxyestrone. 4-hydroxyestrone is carcinogenic. We have this phenomenon called estrogen dominance, and the estrogen dominance is seen between the ages of 35 and 50 usually. Women are down-regulating the production of estrogen by about 30-35%, but markedly down-regulating the production of testosterone and progesterone, such that they get this physiologic estrogen dominance. This is exacerbated by the estrogens in our environment. So there's synthetic estrogens in commercial meat products that are put in there to tenderize them. There are xenoestrogens that are from herbicides, pesticides, insecticides, fertilizers, plastics, plastic breakdown products like phthalates, bisphenol A. These things are construed by the body as being estrogenic. They sit on the estrogen receptor. There are phytoestrogens from soy products. And then low iodine levels can overexpress estrogen in the body. So we have this tremendous estrogenic effect. So, again, that's where it comes from. So the signs of estrogen dominance. And when I talk about this to my men patients, and I start drifting into this discussion, I'll say this is what we see in estrogen-dominant women. PMS is severe, anxiety, agitation, depression, insomnia, fluid retention, fibrocystic breast disease, polycystic ovarian syndrome, endometriosis, uterine fibroids, mood swings, pain issues that are just kind of vague. They're kind of lumped into fibromyalgia. We'll see things like loss of libido, heavy menstrual flows, fat gain around the middle, tendency to form clots, etc. Every time I discuss this with one of my male patients, they say, "Do you know my wife?" But this is a very, very common phenomenon in women who are premenstrual. What happens next is when they go through menopause, we have then the loss of estrogen. Rather than estrogen dominance, we have the loss of estrogen. We have a different type of presentation clinically. Night sweats, you have these vasomotor phenomena. So we have night sweats, and we have things like hot flashes. We'll have brain fog, loss of memory, fatigue, your genital symptoms. They sneeze and you have urinary incontinence. Or you have dry vaginal mucosa with some pain with sex, or recurrent urinary tract infections. Very common with low estrogen. Estrogen is needed for the plumping of that vaginal mucosa and for the sphincter tone within the bladder. Palpitations we'll see low libido, we can see weight gain, and hirsutism, and hair loss on top, acne, and of course depression. So we replace again with bioidentical hormones for obvious reasons. I don't want to use anything synthetic that doesn't sit on the receptor properly. It's not metabolized properly. Why would anybody give desiccated horse urine to a woman? It makes no sense intuitively. It's loaded with estrone, first of all. Estrone can be toxic. And horse estrogen, you have no receptor sites for equilin and hydroxyequilin. That's what Premarin is, pregnant mare's urine. When I give estradiol, because everybody's paranoid about estrogen causing cancer, because of the Y study, the Women's Health Initiative, which in my experience is probably one of the worst designed studies in history, looked at 67-year-old women, most of whom were obese, most of whom were smokers, and put them on pregnant mare's urine and medroxyprogesterone, which is a known carcinogen. And then they found they had problems. And it's like, doesn't really make any sense. But interestingly, if you just look at that arm of the study that used Premarin in these women, they had no breast problems. And looking at studies out of Europe, Fournier, who is using in some instances only using estrogen, has no increased incidence, no matter what kind of estrogen it is, has no increased incidence of breast cancer. However, estradiol does break down into the 4-hydroxy-16-hydroxyestrone and has some carcinogenic capacity. To ameliorate that, I give it with estriol. Estriol sits on the estrogen receptors and displaces some of these more toxic derivatives. I add progesterone. Progesterone has an anti-cancer effect, especially on the breasts. So does testosterone. So does DHEA, melatonin. The oxytocin, free T3, human growth hormone, and vitamin D3 all have an anti-cancer effect. They're all added whenever I'm using estradiol, and I always use it topically with estriol. The other thing I do is that, again, this is the 4-hydroxy and 16-hydroxy estrone derivatives have the carcinogenic capacity. Therefore, I want to push it toward 2-hydroxy estrone, and I want to also to stimulate methylation. And I stimulate the methylation, and I push this away from the 16 and 4-hydroxyestrones by using certain botanicals. So all women on any estrogen, I put on B12, B6 folate. I put them on antioxidant free radical scavengers, and there's all kinds of good ones out there. I use OPCs or Protandim. I put them on sulfur-containing amino acids that help with methylation. And I put them on cruciferous vegetables, so broccoli, cauliflower, cabbage, etc. That contains DIM, diindolmethane, and 3-indolcarbinol, both coming from cruciferous vegetables. They help metabolize, they help methylate these intermediates to help obviate the potential for cancer, since there's such a big scare with this. And really, when you look carefully at the data, using estradiol especially, no increased incidence, even if you're not doing all these other things, no increased incidence out of Europe in their studies of breast cancer. Progesterone, there's the medical people or the medical establishment would like you to believe that progesterone equals medroxyprogesterone or the progestogens. Nothing could be further from the truth. Medroxyprogesterone, which is Provera, is from an androgen, which is like testosterone. It's not even a good progesterone-like agent. Its effects and its side effect profiles are radically different than progesterone. Progesterone is really a sweet hormone for women and a little bit also for men. What it will do is it upregulates the insulin receptors, and when it does that, as I mentioned, less insulin, lower blood pressure, less insulin, lower cytokines, lower inflammation, less insulin, less activation of the enzymes that push up triglycerides and push up cholesterol. So there's less activation, for example, of glycerol 3-phosphate dehydrogenase, the enzyme that pushes up triglycerides. But even apart from that, progesterone tends to cause these effects. And it will increase the elasticity of the blood vessel walls, lowers insulin, it increases what we call parasympathetic tone, and it blocks aldosterone receptors. Aldosterone is the hormone from the adrenal gland that will stimulate your kidneys to hang on to salt and water. So when it blocks that, it makes you urinate. So women who take progesterone, I have them take it about a half an hour or 45 minutes before they go to bed, because if they don't, they'll have to get up in an hour and urinate because of that effect. But the diuretic effect, the parasympathetic tone increase effect, lowering insulin effect, increasing the elasticity of these smooth muscles, all these effects bring down blood pressure. So progesterone is good for blood pressure. Progesterone protects the breast from breast cancer. Progesterone vasodilates the coronary artery. Progesterone increases neuronal stem cells, which increase the production of neurons in the brain. We used to think we couldn't grow new neurons. Progesterone stimulates the neuronal stem cells to grow. Progesterone will convert into allopregnenolone. Allopregnenolone is a breakdown product of progesterone that sits on the GABA receptors. The GABA receptors are where Valium and Xanax work. So they're natural sedative hypnotics. So instead of taking Xanax or Valium or Versed or Ativan, you take the progesterone, and it's your nature's own sedative hypnotic. Patients that have traumatic brain injury or stroke, we give progesterone because it limits the amount of inflammation and limits the amount of damage in the brain. This is not widely known, but in experimental studies, this is what it does. Again, this is the pathway. Progesterone comes right down from the pregnenolone on the left there, and the ovaries, again, are producing progesterone and estradiol. The adrenals produce some progesterone. In men, most of their progesterone comes from the adrenals. In men that I check, oftentimes they have negligible or very low progesterone. I put them on 1/10 the dose I put on women at bedtime, and generally it really helps sleep. And again, this is the pathway. Now, testosterone. Testosterone is made in all the adrenals, the ovaries, and of course the testicles, where you're making most of it. Again, this is the hypothalamic pituitary, the gonadal axis, and the hypothalamus are producing growth hormone releasing hormone, and then that of course stimulates the anterior pituitary to make luteinizing hormone, follicle stimulating hormone. Follicle stimulating hormone tells the Sertoli cells to make sperm, and the luteinizing hormone tells the Leydig cells to make testosterone. Testosterone goes up, it has a negative feedback inhibition on the brain and the pituitary, so to downregulate these pituitary peptides. Now, if this man has got a lot of visceral adiposity, a lot of fat, belly fat, that fat contains aromatase. The aromatase is going to convert the testosterone into estrogen. Estrogen is a very, very potent negative feedback inhibitor, much more so than testosterone. So not only is this guy going to make estrogen from his testosterone, but that estrogen is going to reduce his production of testosterone. And if you superimpose on this all of the xenoestrogens in the environment, I think you have a reason why we're seeing this pandemic of low testosterone in men. Because you're getting, from herbicides, pesticides, breakdown products of plastics, etc., you're getting xenoestrogens that are, and then also the food we're eating that's pro-inflammatory, that's pushing up our production of estrogen, because that activates aromatase. What we're seeing then with that is this significant downregulation of testosterone production. 50 years ago, over the last 50 years, every decade, total testosterone and free testosterone has dropped in the male population of this planet. And it's going down further every decade. And nobody is asking what's going on here. I think it's because of the xenoestrogens. I think it's the same thing that's causing women to be estrogen dominant and have these symptoms. I think it's the same reason why you have 9-year-old girls starting their periods, is because you have way too much estrogen effect. And so how to get around that, of course, starts with nutrition. You eat organically grown fruits and vegetables. Again, testosterone comes over here, and testosterone converts to dihydrotestosterone. Medical society or medical establishment says dihydrotestosterone is a bad testosterone. It's the evil twin of testosterone. BS. You need it. It's 4 times more anabolic than testosterone. If you have too much of it, it can cause acne, male pattern baldness, it can cause hirsutism, it can cause some hyperplasia of the prostate, but you need the dihydrotestosterone as well. You'll need some of it. By the way, finasteride, which is Propecia or Proscar, downregulates this axis, can downregulate this axis forever when taking this stuff for as long as a week. And I'm seeing this in the clinic. And the makers of Propecia, finasteride, are being sued with class action lawsuits. There's as much as 70% of men that are on this stuff are having side effects from it. So a lot of men are worried about losing hair. They're losing a lot more. What's happening? Okay, so how to get your testosterone up? Men and women both need testosterone. There's a current worldwide pandemic. Again, I think it may be due to the xenoestrogens, phytoestrogens, all the estrogens in the environment. Traumatic brain injury can leave you with a problem, so we're having this counter-coup type of injury to the brain stalk with things like boxing and mixed martial arts and bungee jumping and a variety of things, football, baseball players who get hit in the head a lot. Anything that's causing this concussive injury can downregulate your production of these pituitary peptides that downregulate the production of testosterone. Heavy metals cause inflammation. Any inflammation will increase the production or the conversion of testosterone to estrogen. High stress or cortisol. Cortisol will have the effect of high levels, it inhibits luteinizing hormone, and high levels of cortisol activate aromatase, so it converts testosterone to estrogen. Cortisol, if it's low level, you need some cortisol to augment the release of testosterone, and if it's low level, it increases sex hormone binding globulin, so you have less free testosterone. So we want cortisol and thyroid and these other hormones to be optimal because they work synergistically. So it's not just, you can't just look at one hormone and say, we're good. All these things have to be in the optimal range. And then there's a bunch of things that activate aromatase. So high cortisol, high insulin will activate aromatase. Again, aromatase is the enzyme that converts testosterone to estrogen. We don't want too much estrogen in men. Low zinc will do it. Alcohol activates aromatase, especially beer. Beer has hops in it. Hops activates aromatase. Caffeine, drinking too much caffeine will activate it. If you have any form of inflammation will activate it. Taking gugolipid, which is a botanical that's a thermogenic agent, can activate aromatase. Certain drugs will activate aromatase. So we want to keep the aromatase from being activated by various things because, again, in men, it will convert testosterone to estradiol. The biggest thing that's doing this to men, though, I think, is obesity, too much visceral adiposity, and the other thing is that you're having all of these xenoestrogens in the environment, these synthetic estrogens. Consequences of low testosterone. The typical 50-year-old guy that comes into my office, low energy fatigue, depression, decreased memory, decreased functioning. His mind just isn't working as quick and as snappy as it used to. He's got a brain fog. He doesn't remember as well. Testosterone, in fact, low testosterone is a risk factor for Alzheimer's dementia. It's a risk factor for cardiovascular disease. We used to think that high testosterone was a problem, but now we know it's low testosterone is a risk factor for heart disease, unequivocally so. Not only epidemiologic, but prospective studies show this. It's a risk factor for osteoporosis and bone fractures, muscle loss, sarcopenia, and also for fat gain. So when you see the guy that's getting older and he's gaining a gut around the middle and he's gaining body fat and losing muscle, it's very characteristic of losing testosterone. Low testosterone is a risk factor for prostate cancer. We used to think testosterone was the risk factor, but in fact, low testosterone, looking again at the population studies and observational studies, it looks like it's low testosterone. Those men have an increased incidence of prostate cancer. Of course, decreased libido. Erectile dysfunction can be from low testosterone, but erectile dysfunction is generally multifactorial. So it's things like hypertension, diabetes, stress, cardiovascular disease, heavy metals, low estrogen, high estrogen, low DHEA, on and on. A number of drugs will cause that. So it's not so simple. If an elderly guy comes in and he's got erectile dysfunction, adding testosterone often helps, but it may not correct it. And then, of course, low testosterone causes inflammation. It causes mild anemia. So when I give testosterone, what do we get? Muscle anabolism, we get fat loss, bone mineralization, improved cognitive function, especially things like spatial memory and the learning, ability to learn, the rapidity with which you're executing decisions, eventually a bunch of nuanced cognitive functions that testosterone helps with. Improves the mood, better sleep, improved libido, improved erectile function, improved cardiovascular function. It is a direct inotrope of the heart, meaning it increases cardiac output directly, but it has this effect physiologically. What it does, it increases these EPCs. EPCs are endothelial progenitor cells, and those endothelial progenitor cells are what gives you a youthful, robust cardiovascular system. The endothelial cells produce nitric oxide. Nitric oxide tells the smooth muscles to produce cyclic GMP. That's how nitrates work. It vasodilates. So that allows blood pressure to go down. That's less resistance in the impedance vessels and increases cardiac output. So cardiovascular-wise, it's a no-brainer. Same thing is done with DHT, dihydrotestosterone, and human growth hormone. It will upregulate your insulin receptors. So once again, the insulin levels come down. When insulin comes down, we have this significant improvement in the incidence of metabolic syndrome. So that now means insulin is more efficacious, and we now have lower sugars. Lower sugars and lower insulin levels means less metabolic syndrome. Some doctors have gone as far as to say as the epidemic of metabolic syndrome in middle-aged men is principally as a consequence of low testosterone. Now I don't have time to go through all of this, but this again is what we are looking at with insulin resistance. We're looking at the metabolic syndrome, and the metabolic syndrome in large part is due to, in men, low testosterone. However, there is a number of hormones that you take that upregulate insulin receptors. So how we treat patients with metabolic syndrome, of course, would be with optimal nutrition, micronutrients, high-intensity interval training or other aerobics, resistance training, hormone upregulation, and selected micronutrients. The selected micronutrients are things like chromium, biotin, alpha-lipoic acid, vanadium, green tea extract, etc. But the hormones that upregulate your insulin receptors are such things as testosterone, progesterone, topical estrogen, human growth hormone, melatonin, DHEA, free T3, vitamin D3, all of the ones that I'm repleting. So again, conventional medicine, you got metabolic syndrome, what are they doing? They're going to be giving you a statin, they're going to be giving you an oral hypoglycemic agent, oftentimes that further increases insulin, which is exactly what you shouldn't be doing endocrinologically. They'll give you something for your blood pressure, and they're doing this medical cosmetic changes, which are really not addressing the underlying physiology. So I was told I got 50 minutes, and I got to open it up for questions if you have questions. I know it's a mouthful. I want to apologize if I got too technical, but I know you guys have science backgrounds. You're all very smart, so I kind of let it rip here from my last talk. My last talk was in a Catholic parish, and the average age of the ladies there was about 80 years old. So I had to dumb it down a little. So this one I kind of smarted up a little bit. So.
Just a quick note, if you are watching online, feel free to email me some questions at mmcdowell. These slides will be posted when we archive this session, so if you want to go back and review those. And Dr. Haake also has a really good website. It's boisemedicaldoctors.com.
Yes.
So there's a ton of information there as well. Any questions in the room from our audience?
Yes, ma'am.
Oh, when you talked about the free radical scavengers, were you referring to the detox process of the exercise, iodine, vitamin C, or what?
Well, yeah, I guess you could construe it as detoxification, but the free radical scavengers are polyphenols, so they can be red wine extract, grapeseed extract, pycnogenol,
So that's another
et cetera.
category.
What's that?
That's a separate category.
That's a separate category, yeah.
Okay.
So when we're talking about detoxification, we're really trying to get rid of the things in our body that shouldn't be there. So heavy metals, petrochemicals, halides we're exposed to. We used to have enough iodine in our food and our flour and our salt and whatnot. Now we don't. And we may have enough iodine to keep us from getting a goiter, but it's not enough to be optimal. And when you check this, as Guy Abraham did with an iodine loading test, he finds 96% of the population has inadequate iodine. And we need iodine for all of these different things. And you look at iodine, there's an inverse relationship between iodine and cholesterol levels, iodine and cardiovascular disease, etc. So iodine can help displace these halides that are toxic. Halide's also a chelator of heavy metals. Iodine is, excuse me. So I'm talking specifically about that type of thing. Vitamin C can chelate some, but I'm going to start developing protocols that use things like zeolite and EDTA, which is sort of a high-powered form of vinegar, acetic acid, diethylene.
Used for detox.
For detox, yeah, because it binds these heavy metals. Heavy metals are pro-oxidative. They cause this inflammation in the body, and so. I think that's very important. I think that's overlooked a lot of times, but the problem is to get enough data to know how to do this economically and efficiently. And this is something you end up doing the rest of your life just about, because you're exposed to it just ubiquitously, you know?
So like for us, we would need to come and have lab values done to know how much iodine or like
well,
how much
what I do is
vitamin C or
I
that
generally,
kind of
since 96% of the population is low, I generally just put you on some. Now, if women come in and they say, because like I said, what iodine does is that it upregulates the expression of estrogen in your body. For example, low iodine results in low levels of lactoperoxides. Low levels of lactoperoxides increased estrogen receptors in the breast. There's already 15 times more in the breast than other tissue. It also results in low T3. Low T3 results in low sex hormone binding globulin, meaning more free estrogen. More free estrogen, more estrogen receptors. Guess what happens? You have over stimulation of these cells, and they undergo heavy mitosis or heavy proliferation. So you get lumpy, bumpy breast. You get sore, tender, lumpy, bumpy breast, or fibrocystic breast disease. I've placed women on iodine. In those cases, I'll check with an iodine loading test, and a lot of times I'll start them on 25 milligrams a day or even higher. And some women I've had within a couple of weeks, they no longer have fibrocystic breast disease. And one lady with breast cancer who had bad fibrocystic breast disease, put her on the iodine, went back to her oncologist who was checking her, and she said, "What happened to your fibrocystic breast disease? It's gone." And it's remarkable. And I don't know why conventional medicine doesn't latch onto this.
So I guess what I'm trying to decide for myself is, can I do a detox on my own, or do I need like?
Sure, you can do a detox, and I think real simple things: sweat, take in water, take in iodine, vitamin C, and then there's other things out there available online: zeolite, EDTA, DMSO. There's things that you can get over the counter. I'm just trying to develop a protocol that would be cost-effective and smart for everybody, and easy.
And so the 25 milligrams for the iodine, like we could.
I would put you on 12.5 unless there's big-time fibrocystic breast disease, or I checked you.
Yeah. Okay.
There's a consideration about toxicity, but the point is that you generally don't absorb more than you need. So that's what's happening. When you take 50 milligrams of iodoral, which is iodide and iodine, you're going to excrete 90% of it. You should only absorb 5 milligrams or 10% of it. But we find women absorbing 20, 25, 30, 35 milligrams of the iodine, which is a tremendous amount, meaning the body is screaming for iodine. And iodine concentrates not only in the thyroid, but in the breast, in the ovaries, in the uterus, etc. So women have more competition for iodine in their thyroids than men do, which may account for the fact there's 7 times more hypothyroidism in women than men.
And like on vitamin C, I know there's been varying, conversations about how much and what's you can over.
Well, vitamin C, the only problem with vitamin C is that if you get too much, you can have bowel intolerance. Yeah. Above 10, you can have diarrhea. And the other thing is that vitamin C is, if you've got calcium oxalate stones, 80% of kidney stones are calcium oxalate. Kidney can break down, vitamin C breaks down into oxalate, and that can be a problem. Apart from that, no problem. Vitamin C goes down very rapidly. You need vitamin C for type 1 collagen, which is the matrix of all the tissue in your body. When vitamin C is too little, collagen breaks down dramatically. It's called scurvy. We take enough. The recommended daily allowance from the FDA is enough to keep you from getting scurvy, but not optimal.
That's pretty low. So what would be a suggestive dose for?
I give my patients, I put them on, if they have adrenal problems, I put them on 5. Otherwise, I put them on 3 or 4 grams a day, 1,000 milligrams a day, and 3 or 4,000 or 3 or 4 grams a day. If they have adrenal problems, I put them on 5. When they get sick, I double it.
Cool. Thank you.
You're welcome.
Anyone else? Yes.
For a typical postmenopausal woman who's a little pudgy and a little foggy and makes an appointment at your clinic, what would I expect?
Well, you're going to spend about a half an hour doing a history, and then I do a thorough exam, but I don't do the gynecological or breast exam. I defer that to another doctor. I got a doctor I use for that, or you can just go to your doc. And then I do a whole battery of tests, and they pretty well overlap in most patients. And if there's a lot of fatigue, I'll check your adrenals, and I do saliva cortisols for that. Saliva is better for a few things. Urine is better for a few things. Mostly it's blood that I get. And I think you have to take anything that you get, it has to be done properly at the right time, and then you're taking it with a little bit of a grain of salt because it's a snapshot in time of what you're doing. So it has to correlate clinically. Basically, I'm repleting hormones. I get the labs to make sure that I'm not giving you too much or giving you enough. And so it's usually a serial check of these things over months, and I'm titrating to clinical efficacy. So you come in and you say, geez, doc, I feel great. My energy's through the roof. My brain is working great. And look at these guns. I know then I check your testosterone levels. I've overshot the testosterone. When women showing me their guns, their testosterone might be a little high. That's because it's not normal behavior for women to show me their guns.
Anyone else? Cheryl?
I've got a quick follow-up on that. If you're already on existing blood pressure, cholesterol, even triglyceride medicines, how do you work that into transition onto your idea of what the...
Well, I just try to wean you off. You know, once I see that you're improving on those medicines, your blood pressure looks good, and your cholesterol, triglycerides are coming down, and indeed I see it. I have men coming in sometimes with triglycerides greater than 400. They're now in the 90 range, 80, 90 range. And I haven't done anything. I haven't put them on any statins, no cholestyramine or anything to bind the triglycerides. And I see that they're doing well. So when I see clinically that you're doing fine, I'm just trying to gradually wean you off that stuff.
My question is sleep related. I wake up every 2 to 3 hours a night. And what practical things can I do to improve?
I would take melatonin. Melatonin, by the time you're in your 30s or 40s, is already depleted. Melatonin comes from the pineal gland, and it will help you reduce your body temperature. It helps you fall asleep, cycle through the various stages of sleep. It's a potent antioxidant, free radical scavenger. It's anti-inflammatory. It protects your brain against Alzheimer's. It's an anti-cancer agent. It's used by the Germans for cancer. It upregulates your insulin receptors. It stimulates human growth hormone release. That's about 1/3 of the things that lowly old melatonin does. The other thing I would do is I'd make sure your progesterone levels are adequate. For women, progesterone should be somewhere between 5 and 25 nanograms per milliliter. And when that's the case, when your levels are there and you're on adequate melatonin, most women sleep beautifully through the night. And that's the biggest thing that women will recognize, is that when their progesterone is where it should be and they're on the melatonin. And if you don't sleep, everything is screwed up. If you don't sleep, you're going to get depressed. If you don't sleep, you may have blood pressure problems. You'll have fatigue. You'll develop adrenal fatigue eventually. So it's so essential to have sleep, to get your sleep. And then some people may have obstructive sleep apnea as well, and I try to glean that out from the presentation. But progesterone and melatonin is a big twosome there.
So in talking about the way you test for these hormone levels,
yeah.
You mentioned saliva, you mentioned urine, you mentioned blood. Can you just kind of give us a quick overview of if somebody walks into you, what do you do? How do you find those levels? What are you looking for? How do you look for it?
Well, say, for example, I have a 50-year-old man that comes in, and like the guy I presented in the initial presentation, he comes in and says, you know what, Doc, I'm just dragging all the time. I got a lot of fatigue, no energy, brain fog, I can't remember anything. I've got low libido, I can't sleep, I'm getting fat, I'm losing muscle, my endurance is down, my mood is poor. Well, conventional medicine gives drugs for all those things. What I would do is I'd scope immediately. I'd say this guy's testosterone is likely low, but I would check also his DHEA. I would check his insulin-like growth factor 1, IGF-1, which is mediated by human growth hormone. There's a lot of overlap of symptomatology between low growth hormone and low testosterone. I look at his thyroids. I look at his cortisol levels. If fatigue is a big component, I would get saliva levels to check cortisol levels. We have this phenomenon called adrenal fatigue, where the adrenals are being pounded so much by stress reactions that after a while they quit making enough cortisol. You need cortisol for stress. And so the best way to check for that, we found, is likely doing the saliva cortisols. Now, classical endocrinologists, most of them, and other doctors will say, oh, there's no such thing. There's no such thing as adrenal fatigue. Well, so what you're telling me then is that you have perfectly normal functioning adrenals, or you have Addison's disease. You know, you're in myxedema coma, or you have normal thyroids. They don't do that. I mean, there's gradations of this. So in people that have what appear to be adrenal fatigue, we give them supplemental cortisol, and we give them the precursors of cortisol in that pathway. So we give them progesterone, we give them testosterone, we give them pregnenolone, and they end up and DHEA, and they end up pushing those intermediates toward the production of cortisol. So you know, it depends on what the presentation is, but I get so much overlap in what people are complaining about that I usually end up checking most of these things anyway. I mean, almost by convention I do. Got a question, Deb?
I was just going to, I don't know if this is what he's getting at or not, but individuals who come into the office, you see them and do a history and physical, you give them a lab requisition, they go away, they get their labs drawn, you get the results, and then they schedule another appointment where you go over their lab results, and that's how you tell them where their range is, and you recommend what you
Yeah, what I'm really looking for is cooperation. I'm looking for people who are motivated to be healthy. I'm not taking this paternalistic approach that a lot of doctors do. I go over there, in fact, I go overboard. I'm giving too many lectures. But I'm going over their lab, I'm explaining things to them. I want them, this is a cooperative. They're not going to get the results that I want unless they're cooperating, unless they're on board with me, unless they're doing the exercising and eating properly and taking the stuff I put them on. And what I'm really trying to do is arrest or slow down this aging process and to recover some level of physiologic youth by doing this. And I really have to have them on board. And so I spend a lot of time with the patient going over things and answering questions, explaining things.
It's not overnight.
Oh, and I was just going to say, wouldn't you say that it's over the course of a year, you'll see a new patient usually 3 or 4 times?
Yeah.
Until you see that they are.
And they're doing fine, and generally we'll go like twice a year thereafter. What were you saying, Mark?
I said it's just not overnight. It's something like you just said. It has to be somebody you buy into.
Right.
You're somebody who wants to make them healthier, and you have to want to be healthy.
Exactly. So I can always tell when people come in and they're like, what, I got to exercise? I got to lift weights? You know, yeah, you got to pump iron. It can't be this, I just want to tone stuff. You got to go in there and get after it, you know. And if they're not up for doing those types of things, I know they're not going to do as well because they're waiting for somebody to do it for them. It's really the patients have to be motivated to do it. Mark is one of my patients. Mark Fisher, you guys know him, and he's an ex-football jock there that now looks like he's ready to play next year for the Broncos. and he recently had some back problems, which are now is that now good?
Yeah.
Good. Yeah. So how you feeling?
Good.
Good. I'm glad you said good because.
Thank you very much,
Oh, you're
Dr.
welcome.
Haake.
You're welcome.
Thanks everyone for attending. If you could sign in, please.